Well, good morning and welcome everybody. On behalf of the Symptom Control and Quality of Life Committee, I'd like to welcome you to our S2013 Kick-Off and S1614 Reactivation meeting. We're going to tackle these two important studies one after the other, starting with S2013. And there I'd like to introduce Dr. Krishna Gunturu to talk about the iCheckIt study. Krishna, take it away.
Thank you very much, Dr. Fish. Hello, everyone. On behalf of S2013 or iCheckIt study, we'd like to welcome you to the kickoff meeting. So this is the outline of our presentation for the next 20 minutes or so. And this is a schema of the study presenting how the study is conducted. So we'll go into the details of this study in a little bit later, just to give you overall view. Once participants are consented and registered, they would get baseline evaluation and would also get regular standard of care treatment for their treating oncologist. While they're on the study, they'll get the basic standard treatment, and they would get 4 more times all these evaluations, and at the time of grade 3 or higher evaluation. The whole study is for 1 year. So we'll go into the details. By now, I don't need to talk much about what immune checkpoint inhibitors are and how they have transformed our cancer treatments. We are also learning a lot about serious immune-related adverse events, or IRAEs, which are seen in 20 to 30% of treatments with the immune checkpoint inhibitors. We're also learning these IRAEs are unpredictable, and sometimes they are irreversible too, and they can be permanent. And these incidents can vary. We're also learning most of the data from the retrospective analysis. The prospective analysis from the clinical trials enrolled participants who have robust performance status with smaller number of comorbidities or no comorbidities, which is in contrast to our real world or in-clinic setting, where we see most of the time comorbidities or frail patients. So also, other thing is patients experience these subjective adverse events, IRAEs, for example, fatigue or rash, which we may not capture in our regular CTCAE or adverse events. And this is also poorly understood, the burden of these toxicities on our patients. So that's why we designed to collect longitudinal information on IRAEs and patient-reported outcomes in the daily practice to identify patients at risk. So the primary objective of this study is, 1, to develop and also to independently validate the risk prediction model for the IRAEs, which are grade 3 or higher non-hematological, for patients who are receiving ICI therapy for solid tumors in their first year of treatment. So this is a prospective observational study. The secondary objectives of the study also includes any grade of non-hematological IRAEs and grade 4 hematological IRAEs on ICI-based therapy. We would like to get patient-reported outcomes and long-term toxicities of these chronic grade 1 or grade 2 toxicities information, which is a toxicity over time. We also plan to track the patterns of treatment of IRAEs and the toxicity resolution to understand these IRAEs better. Eligibility for this study is for any patients who are receiving immune checkpoint inhibitors for FDA or NCCN category 1 or 2A, solid tumor patients. If they're enrolled in another clinical trial, they would not be eligible for this study. Only exception for this trial is Alliance trial, which I'll talk a little bit later. So anyone receiving immune checkpoint inhibitor alone or in combination with another immune checkpoint inhibitor are eligible for this study. And they should have recovered fully from prior treatment side effects and able to complete the patient-reported outcomes in 3 languages, any of those. If they have received ICI previously It should be more than 180 days before, prior to registration. And they did not previously discontinue the ICI because of IRAE. One point I want to stress is patients who are receiving ICI, in addition to chemotherapy, biologic therapy, or targeted therapy, would not be able to participate in this trial. This would be mainly for immune checkpoint inhibitor alone as a monotherapy or in combination with another immune checkpoint inhibitor. So these are all the possible treatment options that patients can receive. And we understand that these keep changing. So most probably, if they fall into one of these categories, they would be eligible for the study. And these are the top 10 key immune-related adverse events IRAEs we're focusing on, which includes myocarditis, colitis, pneumonitis, hepatitis, endocrinopathies, dermatological, nephritis, neurological, myositis, and hematological toxicities. So our accrual goal is 2,000 patients, taking into consideration some ineligible or ineligibility or dropout. So the goal is 57 participants per month. We're also proactively planning for diversity and inclusion by partnering with ENCORE sites, Latin American SWOG initiative, and with our Canadian groups too. So PROs will be in Spanish and French too. Stratisfaction factor is ICI monotherapy or with combination therapy. This is the study calendar, which I'll go into detail in a second. So for prior to the registration, so participant signs the consent, and the paper version of PROs will be given to the participants. So once they, at that time, they could pick whether they would like to continue with the paper or ePROs. And once they pick one of those options, they continue with the same for the rest of the trial. At registration, we also get information about concomitant medications, and we get history physical and NCI CTCAE toxicity assignment. They would fill the PROs at this time, and as per the regular standard of care, labs, they would get the blood work for treating oncologist, and they get treatment. If there is archival tissue available, then we would also be requesting that to be submitted. So once the pre-registration is done, there are 4 more time points with another 14-day window that we would receive this information. That would be at week 4, week 12, week 24, and 52. We will get information about the concomitant medication, CTCAE, patient-reported outcomes, and they would get the standard labs. If there is grade 3 or higher toxicity, at that time, they will be filling PRO CTCAE, IRAE form, and also getting blood for biorepository at week 4 and at the development of grade 3 or higher toxicities. I would like to stress here that even though these are the time points that we are focusing on the study, sites would be evaluating CTCAEs in between to know when the grade 3 or IRAEs develop in between. All assessments will continue, even ICI is discontinued, because we know that ICI toxicity can linger for a long time. So this is overview of the PROs or patient-reported outcomes, which includes PROMIS 29, and we're evaluating cognitive function. From FACT-G, we're asking the question, I am bothered by side effects of treatment, to know the burden on our participants. We're also collecting PRO CTCAE, and at the end of the week 52 or end of the study or a withdrawal, we ask the feasibility questionnaire, which is one time. So just to highlight again, when serious adverse events happen, if possible, we would like to collect the blood prior to starting the IRAE treatment, such as steroids or immunomodulatory. If it is not feasible, you can always collect the blood, and please note on the form when the blood is collected in relation to the side effects. They would also be filling the PRO CTCAE form and S2013 IRAE form at this time. Now I would like to pass this to Dr. Joe Unger to go over the statistical design of this study.
Thank you, Krishna. Appreciate that. So just to spend a couple minutes on this, and at the risk of repeating a few things, the sample size will be 2,062 in order to accrue 2,000 eligible participants. And as noted, the primary objective is to use an innovative design to develop and validate a risk prediction model for the development of grade 3 or higher IRAEs. Risk factors will be based on clinical and baseline lab factors. The idea is that this model will enable, hopefully, potentially rapid determination of participant risk of developing IRAE for individuals treated with ICI-based therapy using common factors that are generally obtained during clinical exams and potentially related lab testing, in order to aid in timely decision-making. A two-step approach will be used. In step one, factors that are independently predictive of IRAEs will be identified from among 1,200 randomly chosen enrolled patients that have already been enrolled. This occurs at the end of the study, from which among these a candidate model will be built using a method of what's called best subsets with logistic regression. In step two, the identified model will be independently validated among the remaining 800 patients. The model specification step and the validation step are going to be considered independent experiments and are independently powered with multiplicity handled through the validation approach. We will be relying on a two-sided alpha of 0.05 for the design. Thanks, Christian.
Thank you very much, Dr. Unger. I would like to introduce Dr. Kudrer, who is presenting our translational research.
Thank you so much, Krishna. And Mike,
sorry, Nicole. I think I lost control of the screen, so
that's
if I can forward.
Yes, I think Mike from IT will just have you forward. If you could do the next slide. And thank you so much, Joe, for being here as well. Great. So our key translational objectives are to evaluate, first of all, the cytokine toxicity, the cytox score, which is a composite measure derived from 11 different cytokine levels, both prior to ICI-based therapy as well as after one cycle of ICI-based therapy, as a predictive signature for the development of IRAEs. And second, and maybe even more importantly so, is really to establish a repository of both archival tissue as well as blood, various blood samples, especially plasma specimens, for the potential predictive and or prognostic markers of IRAE risk. Next slide, please, Mike. Thank you. The translational study procedures. So glad we were able to do the longitudinal assessment after all of biomarker assessment as well, which is so important. Was part of a K-award feature that I had, and it is becoming really a new standard also for toxicity research, especially that change from baseline to the first month, in order to also assess the impact of therapy on potential predictive biomarkers. So that's why we have this key feature, and not only assessing blood specimens at day 1 prior to ICI-based therapy, but also at week 4, so that 1 month time point, and we're allowing plus minus 14 days. And then also at grade 3 or higher IRAEs, we allow suspected IRAE. That way we don't have to wait again for the patient to be confirmed until they have their blood draw. So you avoid another extra visit. And once the patient gets worked up for a grade 3 IRAE, or you suspect it is such an IRAE, please go ahead and get that adverse event study blood draw. We also collect existing tumor specimens for banking, archival tumor tissue, and again, the patient does not have to undergo any extra tumor biopsy procedures for this. We're also working on obtaining microbiome, which is becoming very important in the whole IRE space. So please stay tuned for that as well. Next slide, please. The research blood draws are at the same time as the standard of care, ideally piggybacked on after the standard of care blood draw, so avoid contamination with from phlebotomy trauma or central venous catheter anticoagulants. That would be really ideal. They're done at the time, again, of suspected or confirmed IRE, as we already discussed. Also, we really implore you to obtain them before the start of any cancer or supportive care therapy that day, and especially in the infusions, as well as any therapy for IRE, such as steroids. If for some reason it's not possible, please note as such, as Krishna already mentioned. The sample processing is done ideally within 30 minutes for optimal sample processing and avoid the degrading process that happens over time, but we do allow the 2-hour window again if that 30-minute or 30 to an hour is just not feasible that day, and we appreciate if you note the time as well. In general, we have otherwise standard processing. Just FYI, we do require the double spin like several other SWOG studies do as well. Next slide, please. So we're already in summary. Really appreciate the study for patients starting ICI who are not going on a clinical trial. So this is really a study for patients on standard of care, which is so great. So it's not competing. And it's applicable to multiple solid tumors. And consider opening a trial at your institutions, of course. We would appreciate that. Next slide.
Thank you very much, Dr. Kuder. So I would like to thank the whole S2013 team, a lot of work behind. And also I would like to ask Anne-Marie Mercurio from the Patient Advocate to share your perspective.
Okay, so I think it's important for anyone that's going to be opening this study to realize that this isn't a significant burden on patients that are going to be administered an immune checkpoint inhibitor therapy. The blood draws are in conjunction with their normal visits. With the exception of if there's a grade 3 event, which would draw them into the institution anyway for treatment. I think layering the PRO data, the way this was all set up with the clinical findings within the blood, there's a rich opportunity to identify the things that may be driving these adverse events. And at the end of the day, it's all about quality of life, because we all want to live good lives, but we all want to be able to survive our treatment. And I would encourage anyone that's able to open this to please do so.
Thank you very much, Anne-Marie. Dr. Hillis-Cohen, can I ask you to comment on the blood specimen for banking quickly?
Yeah, thank you. Thank you, Krishna. I just, when Nicole was presenting the slide, I just realized the blood for banking should be, plasma and PBMC. The processing is a little different from processing into buffy coat or whole blood. So, that part should be corrected.
We also have the buffy coat as well, soon.
Thank you. Thank you very much. And Dr. Fish, should we open for questions and answers?
Sure, this is a great time for that. And one question that came through already on the chat had to do with the fact that we're not including patients who are on clinical trials, but there are some basket trials where people get screened and may not have a mutation, such as on LungMap, and are really being followed for survival only. So the question is, would we be excluding those patients also? And maybe Dr. Unger can address this, but my sense is the way the protocol is written, they would be excluded. if we were to want to include a certain subset of trials or trial enrollees, we probably would have to amend it the way it is now. But I wonder if the study team has any other comments about that particular question.
I think as long as there is no active treatment, I think it is reasonable to enroll, co-enroll on those trials. Because what we, when we're designing this trial, our main goal was to know these IRAEs without heterogeneity from chemotherapy or other treatments. So surveillance would not, yeah.
Right. Right. So that certainly makes sense. I think that's the right way to approach it. I guess my only question would be, looking back at the details of how we have the protocol currently and whether we'd have to adjust anything. So I don't know the answer straight up, but
if it goes
something
in,
for us
most
to look
probably it would be the Amendment 3. Just saying.
Yeah.
So I also see there is another question from Monica Negley regarding the exclusion. If people are getting chemotherapy in combination with immunotherapy and then going on immunotherapy, they would not be eligible for the study because they're just on chemotherapy and there may be heterogeneity of the data. We may not be able to get immunotherapy alone. So let's say, for example, for lung, if someone is getting carboplatin pemetrexed and then goes on pemetrexed, pembrolizumab stops pemetrexed, they would not be eligible at that time. And we will welcome any other questions or concerns from the study sites or the staff.
Well, Krishna, do you want to just mention the social media toolkit and some of the tools that are being developed to help sites communicate about this trial and understand things in plain language? Just a little plug for that.
Yeah. So I'd like to thank our digital engagement team for coming up with the social media kit, Dr. Kareem, Anne-Marie, and Frank DeSanto, working on this to understand easily with a plain language, not our complicated medical language, and to also increase awareness of this trial on the social media, whether it is Twitter or any other platforms, with tweets about this and also newsletters, simply explaining what this study is and who would be eligible and how to reach out. It's also patient participant focused, along with providers too, for everyone. It's geared for everyone to improve their engagement.
Thanks. Yeah, and the nifty thing about it, I think, is that it involves some careful thinking about what those messages will be, and then a chance for the IRB to review and approve those messages before they get disseminated. So it's a very compliant way to communicate about the trial. And so it's a nice innovation to be applied here to check it.
Yes, and this is the first SWOG trial that's going to be using that. So it's kind of exciting. I would also throw in a plug for, the ancillary arm of using the ePro as opposed to the paper PRO, because there's information to be had there. What sites are better with paper as opposed to, and again, reducing the burden on sites and patients that are willing to report their information using their phone or through another tablet type of a device. It stops the need for somebody on the site side having to load all that paper information in. So little plug for that so that we can kind of sort that data out too. I think that's important. It may help streamline the process down the road.
Thank you very much, Anne-Marie.
Thank you so much. Yeah. Oh, go ahead, Krishna.
Another question we got from the sites before, while others are warming up for Q&A, is whether we could enroll on Alliance trial. Alliance, sorry, it's 151216, which is getting blood drawn at grade 3 or higher toxicities, which would be a complementary trial for iCheckIt. So please consider enrolling into both trials.
Yeah, it's a 151804, the Alliance trial from David Gassana, which is it's a biorepository, and we'd like to really support that. And they allow clinical trial patients. So even if it may be too much to do the blood samples for both of these trials, as they both have a biorepository component, theirs is really mainly a biorepository for hypothesis generating data. But we really want to encourage, and again, patients, if they are okay with the extensive blood draws for both, they can go on both. But again, theirs is at the time of IRAE, not at baseline. So it's a very specific IRAE time point and 2 time points afterwards that patients get enrolled. So we really appreciate, especially the clinical trial IO trials, to really consider David's study. And I guess people get due the credit if they enroll for both studies.
Thank you, Nicole.
Well, I don't see further questions now, but we certainly encourage people to continue to contact us as you open this trial and start thinking about how to screen and enroll and experience the trial. We're eager to know, what questions you have, and continuously, spread best practices, and as always, find and solve issues that come up in the course of executing the study. So it's a very exciting study, and we appreciate your support. And thanks for the study team for your presentation.
Mike, can I add 2 more questions that we received from the sites before?
Absolutely.
Okay.
We've got plenty of time.
Thank
Go ahead.
you. So one of the question was, if a patient develops a grade 3 or higher IRAE, does data need to be entered at the time or at the next study calendar time point? So that's one of the questions, because we had only 4 time points, and that's why I was stressing the importance of collecting the CTCAE in between. So that way we know when patients have grade 3 or higher, then we can report it at the next time point. So there are 3 forms that are required at the first development of each grade 3 or higher IRAE. One is the vital status form, and next one is the PRO CTCAE questionnaire for the patient, and the IRAE new form. So additionally, the adverse events form should also be submitted at the time and updated at the next study calendar time point. All of this information is also in the section 14.4 of the protocol. If you have any questions, please send us an email. And one more question is, if someone is on denosumab or any bone modifying agents, if they would be able to go on the immune checkpoint inhibitors and the iCheckIt study, yes, they would be eligible.
Well, so for the study team, many of us will be opening this trial at our sites. And I guess one question that we are asking is, do people see any barriers for accrual? So Krishna, do you, as you think about your own site, as you anticipate, the barriers, what sort of things do you imagine are going to be the hardest steps or hardest parts of this for sites?
I think the biggest is in the healthcare, it's universal, lack of staff. That's the biggest one. Other than that, I had discussions with our CRAs and our study team. They did not see any concerns for submitting. Only thing is for the providers or for the study team to know to follow up on the grade 3 or higher toxicities in between, not just at the time points. So that's one thing, and open to hear other input.
There's
this,
there's a
especially
question in the
microbiome.
box right
Oh.
now about radiation therapy for a bone met and how that might impact eligibility. It's in the chat. It's not in the Q&A.
We did not specify it in the protocol. Other team members, please feel free to chime in. I would say because it is radiation, it is not systemic treatment. I do not see any contraindication to enroll in the trial.
I have to admit as well, unless we think of any language that might, but I would actually encourage that we capture them, and that this is part of, so we understand how radiation may impact the risk. So that's a great question, as all of them.
Yes, they're not explicitly excluded, so I think that gives us an angle there to enroll those patients. And I was thinking about the most challenging part of this study might be executing on the IREs that pop up off schedule, right? And it has to do with linking to the staffing, right? When you know the patients, you can track the patients in your staffing for the fixed time points, but sometimes matching the staffing and the actions to unexpected IREs when you're trying to take action, that's going to take a little bit of thought and planning. That's probably the trickiest execution piece of the trial. That's my guess.
That's, yeah, fully agree, Mike. And again, there with the blood sample, if you can just think of, the patient may be coming in. Again, you don't have to have that confirmed IRE. You're allowed to get that blood when the patient gets worked up, so to avoid any extra hassle, hopefully, for patients and for the team.
Right. And maybe just tracking enrolled patients, even when they're not at those fixed time points, just sort of watching along and quickly figuring out, is there an event here? Do we need to deploy? And kind of watching them as they go. Yeah.
And it does seem easiest, while the event is happening, to kind of get that data. It seems always more time consuming to kind of go post hoc. So if people can, it seems the easiest approach.
Great.
So I'm going to chime in from the peanut gallery, knowing that everyone's dealing with a different, EMR. But if the patient's record is flagged in some way, shape, or form once they go on trial, in the event that they are in between the scheduled visits and something happens, that would help the person that's greeting that person at the clinic, presuming they don't go to an emergency room. How much can you control for? But if they are going into your clinic to be worked up or triaged or whatever it is that whatever the language is in each center, to just be aware of that by looking at the record and saying, okay, we need to grab a vial of blood here so that we can maintain consistency, if that makes any sense, because I'm not the medical person in the room. I'm the peanut gallery when it comes to this kind of stuff. But it seems to me that that's just an easy fix if it's just notated. I know, speaking when I was helping with my mom, I would have been the first one jumping up and down saying, no, you need to take another vial of blood. But you can't put that burden on the patients to realize how important it is to maintain the integrity of a trial by doing everything that we possibly can. So.
And Anne-Marie, I just had another question for you. Would the microbiome be considered an issue for patients? Do you have a sense, have you heard anything from patients how they view microbiome collection, especially if we have more than one time point? Because we were hoping to capture the 2 time points plus at the IRE as well.
I think if you make it clear at the beginning as to why this is so important. This is an area where there's a lot of research going on and a lot of unanswered questions. I think that if a person is willing to participate for the goal of, let's see how this is affecting the inside of our bodies and causing all of these other things to happen. I don't think you'd get too much pushback on that, because I do believe that, you know, again, speaking from like the people that I know, the people that I have the you know, the opportunity to interact with, they're willing to, you know, I don't want a permanent adverse event to affect me for the rest of my life because of treatment. So whatever you're going to ask me to do, I would be willing to step up and do to avoid that. So, but I think it needs to be explained that it's not just for the sake of doing a cool experiment, that at the end of the day, there's bidirectional benefit. There's mutual benefit on the, you know, the research side and on the patient side. It can't just be science for science sake. There, you know, that when you come to certain things that may put people off. So I would say, you know, a good explanation as to why would go a very long way.
That's great. And again, the why here is we think the microbiome may actually be one of the most promising, if not the most promising biomarker that may predict who develops IREs. So it's really to figure out who's most vulnerable for these events. And it would be such a key addition that Sue is helping us to get on this trial.
Yeah, just good explanation to the patient is really the most important piece of that. So
thank you very much, Anne Marie and Nicole. Looks like we have a question. Julie, I think. Would you like to pose the question? Or Julie is our CRA lead from our side, so it looks like she has a question.
Yeah, Julie's on mute. I don't know if we have to centrally unmute or if she can do it.
I think Matt is trying to.
Yeah, while we're waiting for that, this is when just a little bit thought from the last point. It is the most exciting trial, I think, for the IRE field, but it is a lot of burden for the site and for the patient. I think, you know, we probably should have some video or, you know, some kind of education material to communicate with the patient, right? And just let them know what's the significance, why we want them to do this. It's probably a good idea.
Great. Yeah, maybe another dimension to work on with our social media toolkit. I don't know.
Yeah, just some fun video, you know, just to show them, you know, why this is important. Yeah.
Right.
I think we may have to use Clubhouse, my Clubhouse. Or
right. But we don't want to show them the Saturday Night Live clip that was, you know, the bit about stool collection that was on this most recent Saturday Night Live. I don't know if you guys saw that, but that won't show up on our social media toolkit. Humor intended.
I wonder if there's something on NCI's website that we might be able to point people to instead of trying to reinvent the wheel. You know, if there are things that are out there, I'm a big fan of if we're able to incorporate and point people to them. It saves time and as long as it's again, I don't know if it's on NCI's site because this is, you know, I was thinking through that at the same time. I'm like, how do you explain this to people so that they aren't completely turned off at the, you know, the thought of certain things. So, but yeah, I would be hunting around, and I will be hunting around afterwards to see if there's anything that we might be able to use for that purpose.
Yeah, I think even veteran researchers and groups and patients have not necessarily had a lot of experience with that particular specimen collection. So it's going to be good for us to disseminate best practices and good communication tools. And it looks like Julie just accidentally hit the hand raise there. So thanks for letting us know about that.
Thank you. Thank you very much, everyone, for our study team, S2013, who got us here. And now it's all you to get to the next milestone. We are here. We're just in email or phone call away, or maybe on Twitter or Clubhouse or Wonder with a cocktail. So thank you very much for spending your 45 minutes with us. And I would like to thank our whole team and communication team and Dr. Fish for moderating. Thank you very much, and good luck for S1614.
Great, thanks. Yeah, so Dr. Jessica Huang, you're up for the S1614 reactivation, which is a great term for not only what's happening with the trial, but for the trial itself.
Great. Thank you, Mike. Appreciate you, Krishna. Really appreciate learning about your work. Let's go to the study is one that is one of persistence and a lot of support. I appreciate Mike and Lynn and the committee and all of SWOG. It's a randomized phase 3 trial for the prophylactic antiviral therapy in patients with hepatitis B and solid tumors. And let's go to the next slide. So I want to take a moment and say that there's some really great things happening on the national landscape. ASCO recommends now, as of 2020, that all persons with cancer awaiting initial chemotherapy or anti-cancer therapy of a systemic nature be screened for hepatitis B using 3 tests that are marked here, and that anyone with a positive surface antigen or a core antibody would need further evaluation. And this is a fabulous time to do this study 1614, because ASCO's panel clearly notes that large randomized studies are needed to determine optimal management strategies in patients with a solid tumor. Next slide. Wow, we've got some font issues here, but we're going to go forward. In general, hepatitis B affects a lot of people in the US, and these are chronically infected as well as past infection, can range up to 4 to 7% in patients with who are born outside the US, and up to 30% in patients for the past infection who are born outside of the US. And it disproportionately affects persons of racial and ethnic groups. And I want to bring to your attention, most importantly, that it's quite high in patients of Asian origin, up to about 3 to 4% for chronically infected. And in the NHANES, which is noted here in the past infection list, about 18% are these other, is the prevalence in the other group, and that is mostly Asian Americans. And cancer treatments can cause adverse outcomes, including this term reactivation that Mike mentioned, where the replication of the hepatitis B virus comes back and causes a lot of issues, including flares and liver failure and death. And it's really important to note that there is widely available and very effective oral antiviral therapy that can be given concomitantly with anti-cancer therapy to prevent reactivation and these adverse outcomes. And that's what we're going to focus on in our study. Next. And for those who, maybe just a segue between Krishna and Nicole's study and ours, is that there is quite a bit of reactivation risk in patients who are receiving immune checkpoint inhibitors. And in this particular study, where the FDA adverse reporting, and among those who have reported hepatitis B reactivation cases to the FDA from 2014 to 2020, there is a reporting odds ratio that is very high and significant in those who have received Pembro, and it's 2.3. So just keeping this in mind, that these immune checkpoint inhibitors are being widely used, and they are potentially contributing to the risk of reactivation. Next slide. And in one of the larger case series of persons with chronic infection with a positive surface antigen who received anti-PD-1 and PD-L3 therapy, and looking at reactivation definitions that have been both endorsed by ASCO as well as AASLD. In this particular study, the overall rate of reactivation was noted to be about 5%. But if we look at some clear markers of patients who had undetectable DNA and did not receive antiviral prophylaxis, the risk of reactivation could be as high as 21%. This is not an insignificant risk that we're talking about here in these patients who are receiving immune checkpoint inhibitors. Next slide. So there are really no clear guidelines for patients with solid tumors and HBV infection. You know, on the other hand, patients who have hematologic malignancies, the data is quite strong for being on antiviral therapies during anti-cancer therapies, but it's really not clear how to take care of patients with solid tumor. And that's why this study is really important. And we really want to focus on how to best take care of these patients and how to determine whether prophylactic antiviral therapy is needed in these patients to prevent serious outcomes. Next slide, please. So the primary objectives are twofold, and their first one is for chronically infected, and the second is for solid tumors. We would like to compare the effect of prophylactic antiviral therapy versus what we call upon indication antiviral therapy on time to adverse liver outcomes of liver failure or liver-related death in patients with chronic infection receiving anti-cancer therapy. Secondly, we'd like to compare the effect of upon indication antiviral therapy versus the usual care approach on the same time to adverse outcomes in patients with the past hepatitis B infection. Next slide. Again, our primary outcomes are very hard, and this is at the request of NCI many years ago, and that's liver-related death or liver failure as noted here by clinical parameters of ascites, hepatic encephalopathy, or impaired synthetic function measured by a total bilirubin or an INR of 2 if they're not on Coumadin or other things that could affect the INR. Next slide. I'm going to talk about some other clinical endpoints that are very important to practitioners who care for these patients, and that's reactivation. And these are the ASCO and the AASLD definitions for reactivation, which are nicely aligned. Also flares measured by ALT increases that are greater than 3 times the baseline and over 100 units per liter. We're also interested in disruptions to the cancer care and treatment delays and termination of the anti-cancer therapy as well. Next slide. So I'm just going to talk a little bit about the eligibility. They've got to have stage 1 to 3 solid tumor, and they must not have any of the hematologic malignancies and no disease in the liver, no liver cancer, cirrhosis, or any metastatic disease in the liver. And that's simply to make sure that what we're looking at over the time course of the therapy is really related to the Hep B and not other liver disease. They must not have currently active hepatitis C or a history of HIV either. Next slide. And they must be planning to receive systemic anti-cancer therapy, which is single agent or combination of cytotoxic immunotherapy or targeted therapy. Prior or concurrent radiotherapy is allowed, and prior treatment with the same anti-cancer therapy, however, is not allowed. And it's important to remind ourselves that previous treatment with anti-CD20 monoclonal antibody or stem cell transplant is not allowed, but that probably not be as big of an issue for patients with a solid tumor. And they must have discontinued all previous anti-cancer therapy at least a day in advance prior to the registration onto this study. Next slide.
So Jessica, can I pause you for a minute?
Yes.
So first, my apologies that your fonts don't look like the fonts that you created. So we've accidentally, created this glitch in the visual presentation. And I think it can be fixed. And I'm just pausing you because I think our IMS operator has fixed the slides, and I think we can get them to look right.
Oh, beautiful.
I really apologize for that. I know it's the content's there, but I know you're not recognizing the fonts that you intended to show. Okay, so I think we're in good shape now, right?
Yes, I agree. That looks pretty good.
It's just easier to see. Yeah. So again, sorry for that glitch.
No
And
worries.
thanks, IMS operator, for the quick correction.
Well, I'm happy to start up again. If we could get the full view, that would be terrific. Although I'll take it whatever I can get. We were talking about eligibility, and you know, patients really need to have been already tested positive for hepatitis B. They must have a positive surface antigen. Or a positive core antibody, and they must have these results done within 28 days prior to registration. And it's important to note, and this is for everyone, that we really need a total IG or IgG and not the IgM test for the core antibody, and that is simply because the IgM detects acute infection. And what we really need here is to know if patients have been previously infected. Because this is a DNA virus and it lives in the liver, and we just want to know what is latently existing in the liver. Okay, and so we also need to have a baseline hepatitis B viral DNA that has been completed at least 42 days before the registration date. And it's important that they must not be currently receiving antiviral therapy or have received it in the last 90 days to be a participant on this study. Next slide, please. Well, it's really, it's really challenging. I'll take this moment to just pause and say that this has been a very challenging study, but I think it's been really great to have this pause, not only for the pandemic, but also, just trying to get a little guidance on the real world experience on getting antiviral therapies to the right patients. Previously, when the study was opened years ago, we had one drug that was available, and that was tenofovir alafenamide. We had support with Gilead, and through the pandemic, we lost that support, unfortunately, but it allowed us to redesign the study so that we could allow real world antiviral therapies available commercially. There are 3 that we'll talk about in just a moment. And I believe that this will allow lots of patients to be enrolled and to have a real world experience to see how this study would work for the population who are getting antiviral therapies.
And Jessica, I would comment that, it's kind of a blessing in disguise in a sense for the sites to not have to deal with the drug shipments and the sort of the study drug issues. Right now it becomes a chance to just follow standard of care without those complexities in the trial execution. So the super simple way that I think about this is step 1, screen your patients all for HBV according to ASCO guidelines. That is the start. And then step 2, look at the results, and then you can find your eligible patients with chronic or past HBV who have stage 1 through 3 solid tumors that aren't liver cancer. And then step 3, follow the protocol. You don't have to memorize it, just follow the protocol. The protocol tells you exactly what to do when you find these patients. And so screen, find the results, and then follow the protocol. It's a great study. It's an easy study.
Yeah, thanks for your support. And I appreciate the comments that are coming through the chat. And we're going to get this study, and it looks like someone even has some planned study patients coming up this week. So this is exciting. And I'd like to offer just sharing my screen. Do you think I could do that? I've got the slides on another one if this is available. Okay,
Go forward if the system will let you do it. Let's solve it that way.
Let's see. So can you see my screen?
Yes.
All right.
That works.
So let's see if I can. All right. Do you see my full screen?
Absolutely.
Okay, super. So this is a great moment to just pause and say I'm really grateful for this chance to share what we're doing. And thanks everyone for sticking in our technical glitches here. Let's just go back to the eligibility. This is the next slide. These are adult patients who are eligible. And they must have completed their lab testing to assess some general biological workings of their liver and their kidney, so forth. Zoo-broad performance is listed here. We really want patients who are able to be active. They've got to be able to swallow the oral medications, not be pregnant, and not be on certain medications that are currently being under revision, consideration to really streamline this list. They also must be registered, again, less than 28 days prior to the planned therapy, but we'll give them up until 42 days after the initiation of first cancer therapy. And this is really something that the sites who helped us enroll the first couple of patients wanted, was an extended time frame. And we understand this, and we want to meet you where you are. These are patients who are, there's a lot going on. There's a new cancer diagnosis. They're trying to get to therapy quickly, and it's a lot for the study teams to take in. So we've extended this timeline up until 42 days after the initiation of first cancer therapy. And so I'm hoping this is helpful. Our total sample size is 444 patients. That's 222 in each of the hepatitis B cohorts, which will be analyzed separately. All NCTN and NCORE sites are eligible. We welcome full participation. We will try to work with you and your sites to bring these patients on board. And we do plan to stratify our analysis by the planned cancer therapy, whether it was cytotoxic, immunotherapy, or targeted therapy. Here are those 3 antiviral therapies that are now allowed. It's tenofovir alafenamide, tenofovir disoproxil fumarate, and entecavir. All 3 are equally effective. They're all oral agents. And so I just wanted to let you know they are started as soon as possible after registration, and before up to 42 days after the initial dose of the antiviral therapy. They're daily dosing, and we want them to be on the therapy, if they're started, to be on it for up to 6 months after the last administration of their systemic anti-cancer therapy, for a maximum of 24 months, and that's the end of the study time period. There is patient assistance available too, so feel free to reach out to the assistance programs if needed. I'm going to quickly walk through, I don't know how we're doing on time. I'm going to quickly walk through some of the highlights for the study visits. It's in section 9 of the updated protocol, but at registration in about every 4 weeks through the end of the study, they'll need to be assessed. There are some labs, most of them are standard of care labs that sites would usually be inclined to get. There are required specimens, as well as optional, and there's a toxicity review, and if their patients are on the antiviral therapies, there's prescription information and drug diary. If the patient should get reactivation, there's an assessment. There's some required specimens as well as optional as well. And at the follow-up after they come off of their antiviral therapy, there's an assessment in some labs as well. All the procedures must occur within plus or minus 4 weeks of the target dates, and this is based on the data registration. We're trying to allow some leeway here because there are quite a few of these visits. So here is the study schema in general. These are patients with solid tumors, again, with past or chronic infection. Cohort 1 on the left are those with chronically infected. They are randomized to receive prophylactic. So at the initiation of their anti-cancer therapy, they're going to get one of these 3 antiviral therapies, or randomized to arm 2, which is called upon indication. The definition is to your right lower, but these are patients who would be followed, and they would only get their antiviral therapy if their labs indicated that they had actually the reactivation. In cohort 2, past infected patients with solid tumor would be randomized to receive the upon indication schema, or arm 4 would be usual care at the discretion, taken care of by the sites and the physician's discretion. So let's go through treatment, the treatment and procedures for the arm 1, those who get prophylactic antiviral. The sites will, and the patient will choose the appropriate antiviral therapy that works best for the patient and insurance and availability. The antiviral therapy would be treated, will be started before anti-cancer therapy or up to 42 days after the first anti-cancer therapy, would continue for 6 months or up to 24 months, whichever comes first. And these patients, because they have chronic infection of hepatitis B, they may actually need long-term antiviral therapy even after the study completion. And we are supporting this. This is the best way to take care of these patients. So our team has agreed to be available for your patients to help guide you after the end of this study to ensure that they have a good transition plan. Let's go to arm 2, which is the chronically infected, and they are who get the PON indication, or the arm 3, who are past Hep B infected, who also get a PON indication. These patients would have their ALT monitored every 4 weeks, and if they get a flare, which is defined to the right based on their ALT, they would get an HBV DNA level, and only if they get hepatitis B reactivation as defined here by DNA levels or a seroreversion of a surface antigen negative to positive, would they actually even be started on hepatitis B treatment. And then again, the site and the patient would decide which of the 3 antiviral therapies would be initiated if they were to actually get reactivation. And the same parameters would, as with the previous slide, these patients would start the antiviral therapy for 6 months and continue for 6 months. And they would continue it for 6 months after the last dose of the anti-cancer therapy for up to 24 months, whichever comes first. And again, those who become surface antigen positive would need long-term care, and we are committed to helping sites transition these patients for long-term care. Let's move to arm 4. These are the patients with a past infection who are randomized to usual care. They would initiate antiviral therapy, any one of them that's FDA approved, at the discretion of the physician, and follow the usual care approach at the site, whether it's no antiviral therapy, antiviral for all patients, or whatever has been your usual practice. There are translational labs that are required. There are some required specimens for all the arms, and they are at 10 cc's red top, and that can be batched within 3 months of collection and submitted to the SWOG specimen bank. And then there are optional labs, and these are really for, there are 50 cc's, and they're really for some intracellular cytokine staining and ELISA and ELISpot testing. These are conducted and hopefully in the future with our colleagues in Toronto. Currently, we are getting them over to the SWOG specimens bank for future tests. So we're winding up here with the facts, and just wanted to remind us all about the dates. We activated the study in February 2019. We did have to pause, as we mentioned briefly, because of the pandemic and losing some of the support from our Gilead sponsor, and we reopened it earlier this year, and we're all really thrilled. Currently, we have 115 sites that are still registered. 2 patients had been enrolled prior to the break and the pause from the pandemic. And we really hope and anticipate that there might be increased interest and response to the ASCO recommendations for universal screening. Important to note is that all the screening tests are covered by insurance, and that was demonstrated in a previous study, and Dr. Ramsey's study in S1204, and that was confirmed at all the sites that participated. And let's see, the 3 drugs are not supplied by the study, and it goes through your standard of care process of your institution of obtaining medication for a set of patients. And with that, I'm just going to pause and ensure that if you have any questions, my co-chair and I, Anna Locke, or I are available to answer any of your questions and to guide you and work with you, partner with you at the community level to bring in your patients that might benefit from the study. As Mike mentioned before, it's pretty straightforward. You screen at your site, and You screen for hepatitis B at your site as per the ASCO recommendations. And if you have a patient with solid tumor who's positive for surface antigen or core antibody, please consider this. We'll help you take care of your patients with the best knowledge available. With that, I'd like to pause and thank you again for your attention.
Well, Jessica, thank you. That was very well done. And I was thinking about upon indication, which is really like the oncologic term for that seems to be active surveillance, right? This is a treatment versus active surveillance kind of study. It happens to be in the world of viral treatment. And so, like you said, you follow the new and best standard of care, you screen, you find the patients, and then depending on their HPV positive results, whether they're chronic or past, you're gonna have study arms that are treatment versus active surveillance, and you follow the protocol. They're both reasonable. And if you need to get, if you typically get hepatologists or other people involved, they will not be confused by the treatment side or the active surveillance side. They know both very well, and you just guide them to how to follow the protocol and exercise their skills according to the allocation. The protocol is straightforward in terms of what they would typically do. So this is a very easy to execute study. It's just a matter of getting started.
So there, I'm going to read, there's a question in the chat again. What do you recommend if the institution's usual care for chronic or past HPV is to give all patients prophylactic treatment?
Right, I think that's a really great question. Thanks for reading that, Anne-Marie. I think that there is enough uncertainty for patients with solid tumors to just think through the arms. I think for sure for the past infection, I think there is little evidence to support one or the other, and I think there's a lot of safety net in this study where patients are being monitored regularly, closely. We're partnering with sites, and we're going to have eyes and labs with results on patients about every 4 weeks. I'm hoping that that would allow patients who have past infection and their sites to really feel confident that we're not going to miss a Hep B reactivation. And if we find one, we are right on board with you to start the antiviral therapy right then with you. And I think mirroring that, I think there is a lot of support for doing that with the chronically infected as well. These are patients who are quite at risk of reactivation. They're surface antigen positive, but we simply do not have enough evidence to support that all of them require prophylactic antiviral. It is very possible that these patients, if in a well-designed study with a lot of support, like in S1614, hopefully at the end, that we might actually be able to change the landscape and transform care. Because once a patient with chronic infection starts an antiviral therapy, they may actually have to be on it for a very long time, months to years, if not longer. And so it really makes sense to try to get the best evidence out there for patients in the future and their providers to help guide. And that's what we're asking for in this particular study is come partner with us. There's just not enough evidence. The ASCO panel is really clear on the solid tumor patients. There's just not enough evidence. And this, like the panel made recommendations, but they weren't really able to say this is the only way to do it and we have the best evidence. We just don't have that right now. I'm hoping that helps, Anne-Marie. What do you think?
I think we're going to have people falling into two camps here. The people that are not testing at all. So I would encourage all of the people that fall into that camp to follow the ASCO guidelines. And then the people that are doing just, prescribing medication without knowing if there is a real benefit, to just take a breath and wait 4 weeks to see what the blood shows before you jump to throwing another pill at a patient that's already maybe has enough toxicities going on in their body. So 4 weeks is not going to cause liver failure. Or, I mean, I shouldn't play doctor, but I went through this with my mom whose liver, her ALT spiked all over the place. And it was just, okay, we're just going to take an extra 48-hour break and we'll repeat the test to see what happens before we start panicking over, over urine liver failure. So I think we have two camps of people here, and I think that if each side comes and meets in the middle, we have a great study to answer a question that really is important to answer. I hope that answered your question, Dr. Wang.
Well said. Yeah, I think in terms of the camp that's not screening, that camp should just get onto the screening camp. That's an easy one. Then for the second thing, the saying is, in the absence of data, all opinions are valid. So your institution might be treating everybody or might be surveilling everybody. Those are both reasonable. But that's the point, right? In the absence of data, all opinions are valid. Let's contribute to new knowledge. Let's do this study. And then all opinions won't be valid because we'll figure out which one is best for patients. So this is how we learn. This is how we learn in everything. And I don't blame any site that's made their standard one or the other. You got to do something. You got to have some decision about how you're going to handle the uncertainty. But when you can answer it with a trial, you should participate. So this is a great study to contribute to that new knowledge.
Yeah, I think it's a great time to collaborate. I completely agree with you, Mike. And thank you, Anne-Marie, for sharing. It's really great to hear, the patient's perspective and the family members. It is unsettling when a patient with cancer is having elevated ALT. There are multiple things that could be going on. We talked a little about it before in the 2013 study, like patients get hepatitis flares with immune checkpoint inhibitors. They get it from Hep B reactivation. They can get it from liver mets. They could get it from medications, just adverse events. They could have it from any kind of toxicity. So it's really great to just pause. And I agree with you, Anne-Marie, taking a breath. And we are offering working with sites. We are offering like walking down a complicated journey. If your patient has Hep B, we want your patients to be able to have all the amenities of a great anti-cancer therapy journey. And this is one way we can work with you so they can get whatever other therapies they are going to get, and also other clinical trials, because they could be on another clinical trial and be on our trial too. So we're offering support where there really currently isn't a lot of support for patients with Hep B. And they represent a very vulnerable population. So we'd really love to work with sites on this.
There's a question from Dr. Parker about whether infectious chronic or past hepatitis flares occur frequently with, checkpoint inhibitors and immunotherapy.
Yeah, I think, Dr. Parker, that's a great question and one that we'd love to learn more about. And maybe others, as they're going forward, can also include patients with Hep B on their studies or their clinical trials. But the studies are really limited right now. We went over a couple of slides just in this talk. But the adverse reporting to FDA is not, it doesn't have a great denominator, right? But there are cases of reactivation that have been associated with Pembro, but not a lot of others. And what about, we don't really have a lot of information about that, but it is there. It's coming up as signals in the FDA adverse event reporting. In a case series of about 114 patients that we briefly went over, the rate of reactivation was about 5% in patients who got anti-PD-1 or PD-L1 therapy. So that's 5% at least, but it could have been as high as 21% if we really looked at a clean denominator of patients who had a DNA that was undetectable and those patients didn't get an antiviral prophylactic. So it could be as low as 5%, but as high as 20%. This is not insignificant. And that's why I think it is really important to be screening. The message here is screen your patients for hepatitis B using the right hepatitis B test, just like ASCO asked, because the risk is there for pretty much almost any anti-cancer therapy that's systemic. We just don't know how to do it better than that.
Great way to finish. Thank you so much, Dr. Huang and your study team and everybody from SWOG who's participated, and all of you who've joined us for this kickoff pair of trials. Our time is up, and again, thank you very much for your participation, and enjoy the rest of your SWOG experience.
Thank you, Mike.
Have a
Thank
good
you,
afternoon.
everyone.
Bye-bye.
Thanks so much. Goodbye.